All right, so we'll go ahead and get started. Thank you everyone for joining us today on our first webinar really for, I think, the year. The last one that we had was in November, and that one was really fun. It was our first one, so it was a big learning opportunity for us. Today we're using another different platform because we wanted to try to facilitate a sense of networking here. So that's what we're doing here on Zoom. So feel free to look around, see who you know. If you like to chat in the chat, feel free to do that as well. Today, joining us are Jill. Well, let me introduce myself. I'm sorry. My name is Katrina Mitchell, and I'm the program manager at the Georgia Center for Oncology Research and Education, Georgia Core. And in my role, I'm responsible for leading both navigation and survivorship programs for our center. And that is why I'm presenting here today. So I am your contact for CPNG if you ever have any questions or comments, or even if you want to volunteer your services by sharing some of the knowledge that you know within your roles. I'm your contact person. Today, joining us are Jill Binkley and Dr. Marilyn Pink from TurningPoint Breast Cancer Rehabilitation. Jill Binkley is the program manager and founder of TurningPoint Breast Cancer Rehabilitation. Jill has extensive experience as a clinician and an educator in the fields of breast cancer rehabilitation, orthopedic, physical therapy, and also manual therapy. Dr. Marilyn Pink is the executive director of TurningPoint Breast Cancer Rehabilitation, and Dr. Pink has extensive experience as an educator, clinical researcher, and business owner. And thank you both for joining us today and being willing to share your knowledge about this very important sector of cancer care that not a lot of us know a lot about. So I'm glad to have you here today so that we can learn more. If you have any questions during the presentation, please leave them in the chat box. We'll be monitoring that throughout the session today. And then at the end, we'll have some time for Q&A if you have some questions then as well. The webinar will be recorded and we'll have it on our website when it's uploaded, and that'll be at georgiacancerinfo.org/navigation. And it'll be there along with our past webinar from November. Now, I will turn the webinar over to Jill now. Like I said, if you have any questions, just leave them in the chat for us.
Great. Thanks so much, Katrina. Good morning, everyone, and welcome to this new and different format, certainly for me and for most of us. Today I'm going to talk about navigating patients to rehab and exercise, and I'm going to begin with really going over the need for rehabilitation and filling the group in on some of our perspectives to oncology rehabilitation and how TurningPoint and rehabilitation in general can fill much needed gaps in cancer care. And then towards the end, I will turn it over to Marilyn, the executive director of TurningPoint, who will talk about accessing resources both through TurningPoint ourselves as well as in your community. And just let's go over the objectives, although they were shared, but just briefly, thinking about the role of rehabilitation in the management of the physical side effects common to all cancers. Those include fatigue, radiation effects, chemotherapy-induced peripheral neuropathy, and some of the common physical side effects of a treatment that are common to all cancers. Because it's our specialty and we know a little bit more about that, we're also going to focus for the middle section on common physical side effects of breast cancer treatment and the role of rehab. We're going to focus throughout the talk on the role of exercise, and certainly rehabilitation plays a large role in making sure that we're giving patients much needed information regarding exercise and initiating exercise during and after their treatment. And finally, as I said, we'll talk about navigation resources and searching them out. So a couple of quick notes. There will be time for Q&A, as Katrina said. There's a chat going. And just to kick off the chat, we would love to have you post your name and title, the organization, just your interest in the section. It kind of feels a bit odd to tell people to talk amongst yourselves while I'm chatting, but I can't see it. So go ahead and just have at it. But no negative, please. Just to begin with, we talk about rehab, and I realize we should probably begin by defining what I mean by rehab. Depending on the setting and depending on the type of cancer, the oncology rehabilitation team may include a number of different professionals. There are physical medicine physicians who specialize in oncology. As many of you probably know, there are very few of them, though, in the United States, and certainly in Atlanta and Georgia. It's mostly physical therapists, OTs, dietitians, exercise folks, massage therapists are included, social workers, rehab nurses, and again, depending on the type of cancer, speech pathologists, for example, in the head and neck cancer area. Before I go on, wanted to tell you a little bit about Turning Point and sort of where we're coming from and why we're here today. Turning Point is a nonprofit organization, and our mission is to improve the quality of life for women and men going through breast cancer treatment by providing, promoting, and advocating for specialized and evidence-based rehabilitation for all patients, both here at home in Atlanta, across Georgia, as well as internationally and nationally. We provide care as a nonprofit regardless of patients' ability to pay. We have a freestanding clinic that's operating in sort of a half shut down mode right now. Our clinic is in the Sandy Springs area. And as I said, our financial assistance program means that no patients are turned away. And many of our programs are complimentary and free of charge. And they're paid for by grants, donors, and fundraising activities that we do year round and constantly. We have a number of different programs, a collaboration of services designed to meet the needs of women and men during and after breast cancer treatment. Specialized physical therapy for breast cancer, lymphedema education, surveillance, and management, a number of exercise programs, including individual and classes. We do a lot of education for patients as well as healthcare providers regarding important survivorship issues, nutrition, oncology, massage therapy, and support groups, particularly in the area of supporting women going through metastatic breast cancer. All of our programs are now offered through tele-rehab, except of course massage therapy, which we will have to wait until we are open fully again to restart that. Advocacy and promotion, just mentioning it going by, we do a lot of healthcare education locally, nationally, talks like this morning, but also very specific ongoing education courses for rehabilitation professionals so that we can, again, kind of like a ripple in the pond, spread out this knowledge so that we have more and more healthcare providers in the oncology field that can help care for patients going through cancer. So a few quick facts. We have served about 5,000 patients since we started in 2003. We take care of about 700 women and a few men each year going through breast cancer. About 20% of our patients receive financial assistance. And during this crisis with COVID-19, we are offering all of our services free of charge with no out-of-pocket cost to our patients. So, talking about the need, I think probably everybody on this webinar this morning understands that during and after cancer treatment, patients face many physical and emotional challenges. And this is a relatively old study done in 2006. Unfortunately, the data still stands, and it's a study that was that I wanted to present just because it's so, to me, it's very impactful and very sad in a way as well. This is a colleague of ours, Carrie Ness, and she looked at physical performance limitations in all cancer survivors, not just breast cancer, and looked at them within the 5-year window after their diagnosis, as well as 5 years plus. And what she found was that over 50% of cancer patients in that first 5 years, but most importantly, after the 5 years, continue to have physical performance limitations. And while the data is somewhat old now, it's, as I said, it's still valid for today. This is still what we're seeing in cancer patients. There are many national standards that include rehabilitation for patients with cancer, and I don't need to go through them. You're probably familiar with them as well, but we certainly have many national standards that call for rehabilitation for all patients with cancer, and including that in cancer care plans. 60 to 90% of cancer patients have impairments that are amenable to rehab, and this has been shown in many studies, a few references here. But rehabilitation and exercise have been documented to either prevent or at least reduce many of these issues. Sadly, however, most patients do not receive this care. And this is true in Atlanta, it's true across our state, it's true nationally and internationally. This is a major issue. So some of the barriers to care have been identified in the literature, as well as by us at TurningPoint and our experience. There's lack of established relations between rehab and the oncology and surgery professions that are taking care of the medical side of cancer care. And what I mean by that is if you think about having, for example, orthopedic surgery, if you had knee surgery, you would routinely get referred to physical therapy after your knee surgery, generally speaking. If you didn't get referred, most patients would know to ask for that referral and understand that that was an expected part of having orthopedic surgery. Those kinds of relationships and that kind of automatic referral doesn't exist, generally speaking, in the oncology world. I think there's lack of clear guidelines for rehab referral, and that's on us to make sure that that happens, letting people know when you need to send patients to rehabilitation. There is certainly a lack of availability of specialized care. We're working on that in the physical therapy profession. We just began in the last couple of years our first certification of oncology physical therapy specialists, which is a big step forward in our field. The lack of availability of specialized care is even more pronounced in people with advanced cancer. Metastatic cancer are often forgotten in the rehab and exercise world. And there's definitely increased disparity in survivorship care for minorities, lower socioeconomic groups, and in smaller centers and rural areas. Lack of appropriate environments. Often cancer patients don't want to go back to a big gym and begin starting an exercise program. So it's an important part of the rehabilitation care to really look at and evaluate the kinds of settings that we're offering to our patients going through cancer. Finally, many patients have misconceptions regarding expectations after cancer treatment. A lot of times, we feel, and I'm a cancer survivor, so I know this, you feel that you don't want to complain about relatively minor issues like a little swelling or a little lack of mobility, because our physicians and surgeons have saved our lives, and we feel that we need to live with those kinds of issues. So we tend to hesitate for self-advocacy. And finally, financial, but interesting. Insurance pays for most of the kind of care that we're talking about. So it's often not the first barrier. All of those other things are the barriers prior to financial issues. So we're going to talk a little bit about common physical challenges faced by patients during and after cancer treatment. Across the board in all types of cancer, we obviously see fatigue related to surgery, chemotherapy, and radiation, specifically radiation-related issues. Chemotherapy-related peripheral neuropathy, or CIPN. We're also seeing, and certainly in the physical therapy world, there's a lot of research being done related to CIPN with secondary balance issues and increased fall risk in cancer patients that may before now not have been identified or associated with some of the issues related to chemotherapy specifically. Lymphedema, common to all cancers, although today I'm going to talk about it related to breast cancer specifically, but happy to talk about that in the Q&A in other cancers as well. Reduced mobility and function, definitely cardiorespiratory morbidity and osteoporosis. And I'm going to leave those for today just because of time, but they are certainly other common physical issues related to cancer treatment. So we're going to talk about these first, and then I will go into some of the more specifics related to breast cancer. Cancer-related fatigue, we all know about it. I'm not sure that we're all as aware as we need to be in the oncology world about how much it impacts quality of life. It's a syndrome really that affects body, mind, and spirit. It's been identified by cancer patients as one of the most common and distressing problems for individuals with cancer and has a significant impact on quality of life. And this has been shown over and over in research. It's a given at this point. 48% of patients with cancer report fatigue, and almost 100% of breast cancer patients report fatigue as they go through their treatment, and that lingers after, unfortunately. So as I said, it's multifactorial. It can be a direct effect of the cancer, but is also impacted and produced by anemia, depression, nutrition, sleep disorders, which are common in cancer patients, pain, stress, and deconditioning. So there isn't one factor that contributes solely to cancer-related fatigue. From a patient's perspective, it feels unrelenting, very overwhelming. It can make patients feel teary, fragile. Typically, one of the ways we identify specific cancer-related fatigue is that it doesn't go away or it's not reduced in the morning after a good sleep or after napping. It tends to just stay. And it can be like a feeling like you're walking underwater. Takes a lot more energy to do anything and to think through things. So these are just some patient perspectives from some research that we did and published back in 2012. Patients' perspective on fatigue, a lot of times feeling like they should just accept it because at least my cancer is cured or I'm finished my treatment. In some cases, patients actually are worried about it because it makes them feel like their cancer is getting worse. So again, there can be some things that patients think about related to fatigue that we need to be aware of. So even though we see this across the board in almost all cancer patients, research is very clear that aerobic and strengthening exercises reduces fatigue in patients during and after cancer treatment. Unfortunately, many patients are not given this information or provided with guidelines on how to begin and continue an exercise program that would in fact make a significant difference in their fatigue. So from a rehabilitation perspective, our approach to fatigue management would be to include aerobic and resistance exercise, talk to patients about energy management and sleep. Even sometimes sleep comes down to sleep positions and what you might think would be kind of obvious tips related to sleep can sometimes help along with the energy management advice that we can give. Stress management, pain management, because pain can lead to, again, increased fatigue and lack of difficulty sleeping. Manage depression with referrals to counseling and physicians as needed, and definitely nutrition. So an all-round approach to fatigue management has been shown to be very helpful to these patients. And again, lots of research to support this. So moving on to radiation, many of our patients obviously go through radiation, and there are many issues that we look at from the rehabilitation perspective, pulmonary complications like pneumonitis, radiation pneumonitis that obviously is short term, but if we're giving them an exercise program at the same time, something we need to be aware of. Long-term lung changes with fibrosis, depending on the site of radiation, of course. Cardiotoxicity, soft tissue issues, which are initial inflammatory, but later can often move on to alterations in the collagen and connective tissue. So the actual extensibility of tissue, soft tissue, including skin, fascia, and muscle, can be affected by radiation. In one study, with patients up to 4 years after radiation, there was a progressive loss of shoulder range of motion, and that would be, of course, without treatment. So we do see it affecting breast cancer patients' range of motion and mobility, not just at the time of radiation, but significant issues going forward after that. The radiation changes in skin and all of these changes are dose dependent. And we also find that they're more significant with people with impairment in their mobility pre-radiation. So it's something we always look at it in our patients at Turning Point to make sure that they have full range of motion prior to initiating their radiation. Radiation increases our lymphedema risk due to the direct effect of radiation on lymph nodes, and it can also produce neuropathies by damage to the nerve tissue. So from a rehabilitation point of view, we would be thinking about the cardiopulmonary system and in the need to adopt exercise and their exercise tolerance. It can also be something we're considering when we're thinking about fatigue as well. Soft tissue mobility and range of motion. We certainly see issues in breast cancer patients, but patients with head and neck cancers, definitely soft tissue mobility, range of motion of the neck, difficulty swallowing, and those kinds of things can often be related to radiation. And amenable to stretching and soft tissue techniques and other kinds of ways of improving range of motion. In cases where in patients with who have had radiation, we're of course going to be thinking about lymphedema surveillance and management, neuropathy intervention, and for cases such as head and neck cancers, thinking about referral to nutrition and speech pathology. So again, that's not the full breadth of the kinds of things we would do in the rehabilitation world related to radiation, but it gives you an idea of some of the roles that we play with it. CIPN, again, common to all types of cancers, but dependent on the type of chemotherapy that patients may have. It's symmetrical, so we see it in both hands and feet symmetrically. It may affect hands more than feet or vice versa. It presents like a peripheral neuropathy, numbness, tingling, and weakness. But again, the way that we sort of identify the CIPN is obviously going through chemotherapy, but this bilateral effect with nothing else going on orthopedically, we start thinking down the lines of CIPN. It's caused by nerve damage specific to different types of chemotherapy and taxane therapy, Taxol, Taxotere, which is commonly used in breast cancer treatment, is an example of one of the chemotherapeutic drugs that can cause CIPN. It's dose dependent, and sometimes when CIPN is increasing or is worsening, it can actually be something that can delay chemo treatment while it improves. As I mentioned, there's a lot of research. One of our colleagues, Cindy Falzer in Michigan, is doing a lot of research related to balance and increased fall risk in patients that are long-term cancer survivors. And it's due to reduced sensation because of the peripheral neuropathy, as well as reduced proprioception, or a sense of where your joints are in space. And that's a significant issue for patients long-term. And some of the research that they're doing is tracing this back to their chemotherapy. So some of our interventions for CIPN can include exercise. You keep hearing this: exercise, exercise, exercise. Sensitization activities have been shown to be beneficial, balance training, and sometimes some simple things like assisted devices, canes and walkers, etc. But even changing footwear and that kind of thing can help patients who have decreased sensation in their feet and make them more comfortable and improve their balance. So moving on to some of the specifics in breast cancer that we see, in addition to all of the things that we've talked about, breast cancer patients have some additional side effects of treatment, and that can be contributed to by a number of different treatment issues. And I won't go through every one, don't worry, but surgery, depending whether they've had a mastectomy or lumpectomy, axillary lymph node dissection. And we know from research that's been repeated many times that patients with a mastectomy and an increased number of lymph nodes removed have more morbidity after their surgery. Breast reconstruction also brings other kinds of issues related to shoulder and arm problems, core issues, and so on, which we'll talk about. And the other treatments, radiation, chemotherapy, hormone-based therapy, can all add to the physical side effects of treatment faced by breast cancer patients. So focusing on the trunk and upper extremity issues that we see pain, both chest wall pain, breast pain in patients that have had lumpectomies, reduced mobility and strength, axillary cording, which is unique to breast cancer patients and not seen in really any other kinds of medical conditions, decreased function, and arm and trunk lymphedema. The physical impairment related to breast cancer is very well documented, and it's been documented for many years, 20 years or so. We've known some of these things. Upper extremity morbidity early post-op, we see that over 60% of women undergoing axillary lymph node dissection have significant upper extremity arm and shoulder problems post-surgery. In a study by Katie Schmitz that came out in 2012, she showed that at 6 years after their breast cancer diagnosis, over 60% of women continue to report one or more moderate or severe physical symptoms related to their breast cancer treatment. So these are things that are lingering after their initial treatment that are not getting addressed. About 20 to 30% of women develop lymphedema. And the estimate is ranged all over the map, but that appears to be sort of where everything's fallen in the research at this point, is about 20 to 30%. So axillary cording, as I mentioned, this is unique to breast cancer. This is a patient with cording, and the tissue, they've done biopsies on the tissue. It's a combination of lymph tissue mixed with some fibrous or scar tissue, and is directly related to axillary node dissection. We see it, it's increased in patients with mastectomy, and again, the larger number of nodes removed, we see it more prominent. It can be extremely painful, especially in that early post-op period of around a week to 3 or 4 weeks. It can limit range of motion and does limit, and it can be painful all the way from their armpit down into their forearm. We see it probably in about 60 to 70% of our breast cancer patients at TurningPoint, and that's also been documented in the literature at this point. In this patient who's had a mastectomy, she's now 8 months post-mastectomy. You can see that she still has some axillary cording. It's a little hard to see in this picture, but it's there and palpable. Significant tightness in her surgical incision, decreased extensibility. You can see her pectoral muscle along here. It's not supposed to look like that. It's actually very tight, and that's radiation tightness. And we see a lot of patients with decreased extensibility of the muscles in the back of the shoulder, the latissimus, for example, that can obviously decrease their shoulder range of motion. She's at full range of motion for her in this picture. So we do see a lot of more long-term issues in patients as well. So activity limitations. The limitations in function of the upper extremity have been very well documented in breast cancer survivors, and also associated with lower health-related quality of life. We haven't talked about breast reconstruction, and that would be a whole lecture in itself, but just a few little tidbits going by here. The types of reconstruction that patients can have include both expanders at surgery, followed by implants, so a two surgery procedure, and many of you will be familiar with these. The implant is put under their pectoral muscle, which makes it basically functionally shorter. So we see a lot of tightness and restriction in the shoulder related to expanders and implants. Tissue reconstruction using patient's own tissue includes latissimus flaps, where the latissimus muscle, along with skin and tissue, is brought around to the anterior aspect or the front of the chest wall to make the breast mound. There's also transverse rectus abdominis flaps and other kinds of flaps that use abdominal tissue and a wide incision across the lower abdominal area in order to make the breast mound with their own tissue and fat. So suffice it to say, and the reason I brought this this picture up is, again, it's a much bigger topic. However, you can imagine when you're moving someone's latissimus muscle from the back to the front that you're going to have some significant impact on strength, range of motion, pain issues, and so on that we deal with on the rehab front. So the evidence to support rehabilitation, just wanted to do a little bit of that, and then we can talk about how we would manage patients like this. But this is one paper that was a systematic review. So it really includes a lot of studies with a lot of participants. And basically, there's research that has established clearly that physical therapy exercises following surgery improve range of motion and restore strength and function after breast cancer treatment. And there's no risk of increased lymphedema, which we know now, but just to make sure everyone on the webinar knows, there's no increased risk of early mobility after surgery related to lymphedema. So going on to talk about lymphedema, that brings up that topic. As you know, it's a chronic progressive disorder. We have concerns about it in our breast cancer patients. There's a lot of new research over the last 10 years that we have implemented in our practice. It's secondary lymphedema. There's primary lymphedema, secondary lymphedema. That's impairment of lymph flow from tissues back into the blood circulation. And in secondary lymphedema, it's due to damage to the lymph system. Primary lymphedema is either something that's abnormal in the lymph system itself, and there's not a secondary cause. The backup of the lymph fluid results in an accumulation of tissue in the interstitial space, which it results eventually in visible swelling. The damaged or blocked lymph vessels can be caused by surgery and radiation, which is typical in our cancer patients. And there are other causes as well. So in breast cancer patients, the risk factors are very clear in the research now. The risk factors are the number of axillary lymph nodes removed. The greater number of nodes, the greater a patient is at risk. Radiation therapy, especially to the axilla, which is not uncommon in our patients, causes lymph node fibrosis and increases their risk of lymphedema. Soft tissue fibrosis around the area of the lymph nodes and in the upper arm can also add to patients' risk. Body mass index has been clearly associated now with increased risk of lymphedema. And then arm infection and injury has also been shown to be a trigger for lymphedema. So that may be the initiating cause. So when we talk to our patients about the evidence to reduce their risk of lymphedema, this is clearly in our role as rehab oncology specialists. And it's, again, something that often patients we find are still getting off of by Googling lymphedema. And a lot of the information that's out there is not evidence-based and is often old. Back in the days, we used to tell patients not to exercise because it might cause lymphedema. That information, unfortunately, is still out there. And so from an evidence-based perspective, this is the kind of thing that we would be including in an education program for our patients. It should be based on their individual risk. A patient with one node removed and no radiation is at much lower risk than someone with 15 nodes removed who's had radiation. So we definitely want to address that with patients so they know their level of risk for lymphedema. We also teach them about the early signs and symptoms of lymphedema so that we can facilitate early intervention, which has been shown to be much more effective than waiting until they have more significant lymphedema. It's helpful to have baseline measures of upper extremity volume, especially pre-op, because that allows us to do early detection of lymphedema. Lifestyle advice, exercising regularly. Exercise has been shown to decrease lymphedema risk, maintaining that BMI at an ideal. Understanding potential triggers is also important. And again, I'm happy to go back through this, but it just gives you a feel of how we would approach an evidence-based approach to reducing lymphedema risk in our patients. So breast cancer patients may or may not be given hormone therapy, depending if their cancer is estrogen and progesterone sensitive or positive. And there's many side effects to hormone therapy, but these are the ones that are relevant to rehab that we are often addressing with our patients from a physical therapy perspective. Tamoxifen increases hot flashes. There may be other issues related to reduced estrogen. But the hot flashes and some of the other issues we're dealing with on our patients on a day-to-day basis because they affect sleep, they affect their ability to exercise. And so these are just some things that we are aware of. In the case of aromatase inhibitors that would be given to a postmenopausal woman with ER/PR positive cancer, there's many more musculoskeletal implications, and we see this and talk about this in our patients extensively. Osteoporosis, joint arthralgia or joint pain is common. And other kinds of syndromes such as carpal tunnel and tendonitis are associated with aromatase inhibitor therapy. So these are the kinds of things that we would include as we're talking to patients who are on these medications and actually addressing from a rehab perspective. So evidence related to exercise and breast cancer. I've mentioned it probably 20 times during my talk, the importance of exercise for cancer patients. And so I'm cutting it many different ways, but from a point of view of a breast cancer patient, exercise has been shown to reduce our risk of breast cancer recurrence by up to 50%. And that is a known fact now. And unfortunately, again, many of the patients that we see for the first time at Turning Point have not been provided with that piece of information. And I think that's really important for patients to know. This is one place that they can control and that they have impact on their future ability to survive and decrease the risk of recurrence. It's something that they can do themselves. It reduces fatigue, it decreases lymphedema risk and reduces lymphedema when patients actually have it. It improves upper extremity range of motion, strength and function, bone health, and it's an important component, as I mentioned, in treating CIPN and the arthralgias associated with aromatase inhibitor therapy. So exercise, exercise, exercise. It's something we're talking about with our patients every day at Turning Point. So the timing, sort of the when to refer and what we know about the timing of starting rehabilitation programs. So a landmark paper by our colleague, Nicole Stout, was, I think, probably the first paper that kicked off this idea that earlier is better. And it was related to lymphedema. And what Nicole and her group did was they looked at arm volume in a little over 190 breast cancer patients. And what their goal was to identify lymphedema early and to see how effective they could be if it was identified early. Was it better than, again, the current way of having patients come in when it got to a point of really needing care? So they measured patients preoperatively, 1 month post-op, and 3-month intervals for a year. And out of that group, 43 patients were determined to have lymphedema, but it was very mild and very early because they were in this program. And they were treated very simply with over-the-counter compression garments. And what they found was that treatment with compression in the early phase of lymphedema was effective in reducing the volume and effective in limiting the progression of lymphedema. So the patients basically, their lymphedema returned to either little or no swelling, and then they could manage it on their own and learn to actually identify and treat it as needed, and could manage it at that very low level without the progression that we often see in lymphedema. And so their conclusions were that a surveillance program may be useful to successfully detect and treat lymphedema and decrease this progression. So that spawned some work that we did with the prospective surveillance model for rehabilitation for women with breast cancer. And the steering committee pulled together experts from United States, Canada, and indeed around the world to bring together rehabilitation oncology experts, physicians, physical therapists, occupational therapists, and so on. And what we did was we looked at 10 common physical side effects of breast cancer treatment. And again, we were not at that point addressing psychosocial issues, not that they're not important, but we focused on the physical. And we identified 10 physical side effects of treatment. And then we looked at what the evidence was in the literature that supported rehabilitation generally and early intervention specifically. And what we found, and this is summarizing sort of a whole journal and many months of work, but there was mounting evidence in all of those areas that early and prospective approach to breast cancer rehab and exercise appeared to be effective in reducing and preventing all of the treatment side effects that we've mentioned, including shoulder morbidity, lymphedema, fatigue, CIPN, and balance issues. So we went on to create a model of care that we use at TurningPoint that was published in the journal Cancer in 2012, where we suggested a pre-op rehab assessment that would include the things that we've talked about: range of motion, strength, baseline upper extremity volume, and so on, functional level, and then early post-op rehab assessment that would be done at 2 to 3 weeks post-op ideally, or sometime in that early post-op phase. The model isn't prescriptive, it's just a general plan of care, and then ongoing surveillance for these issues. And the time frame for the surveillance depends on the medical model and the medical treatments that patients are receiving. A patient that's having radiation and chemotherapy and ongoing treatment would obviously be within the surveillance program for longer, and maybe at more time points during their treatment. And at any point during the model, when a referral to rehab would be initiated, and exercise consultation, when there was issues that could be addressed by rehabilitation, and then back into the model for ongoing surveillance. So while the model of care that I just presented was done for breast cancer patients, there's also mounting evidence that in all cancers, an early and prospective approach to rehabilitation and exercise appears to be effective in decreasing or even preventing some of the issues that we see with related to physical side effects of cancer treatment. Thank you. I'm going to turn it over to Marilyn now.
We don't see your screen yet, Marilyn. Marilyn?
Okay, thanks. Now there was a purposeful dark slide so that we could transition the two screens, and I was just trying to unmute myself, and lo and behold, that wasn't an option for me. Thanks. And Jill, that was terrific information and a lot of information. So that was fabulous. So I'd like to open the door now a bit and share with you what TurningPoint can do to help support your patients. This is a animated graphic that we just developed last week to share with our patients all the different things that we can do for them when we're sitting in this virtual world of today. The cornerstone to our work is really this tele-rehab or rehab, be it in clinic or tele-rehab. And right now we've adopted a blended approach, and we have found that tele-rehab can be very, very effective. We had piloted this before we launched it full bore. And it was just real interesting that we could see cording, you could see aromas, and we have several of our therapists here in this lecture now. And so if you have any questions about what it is that we can see, I'm sure they'll be happy to chime in too in the Q&A area. But we do have a secure platform, and our therapists are very highly trained because we only do breast cancer. So we're very happy to share our tele-rehab services right now. The next area I'll look at is the emotional support that we can offer to your patients. We currently have monthly support groups that are moving in May to twice a month support groups for people with stage 4 metastatic breast cancer. The counselor again is an LCSW, and she has worked with TurningPoint for years and has really developed an expertise with the needs of people with breast cancer. And we've also launched a survey to see if any other patients have a need for emotional support, because if there is, we're very, very happy to provide this. Education, as Jill mentioned, is an important part of our treatments, as well as we have a monthly educational programs that are virtual. Next week, we are offering a educational session that's on anti-inflammatory eating. And again, if any of you have patients or yourself that'd like to listen into that, please let Katrina know. It's given by our nutritionist, again, that we've worked with for years. And so Lisa is very, very highly skilled in working with the specific needs of breast cancers. In the words of some of the folks that have attended her lectures, she's lively, entertaining, and very easy to listen to. And then in June, we're going to be offering some education on walking as exercise by our lovely Allison, who is here on the seminar today. And then we'll be offering another educational session in July, which is on the emotional support issues that come across for our breast cancer survivors. We will be doing some on caregivers and so forth. So you can just keep tuned in to Katrina or TurningPoint, and so you can see what and when we're offering for education. So our nutrition, in addition to the education sections, we do offer personal consulting. So many of our patients will be taking advantage of that in the near future. Keeping in touch, that's one of the things we've been doing during this COVID crisis. We've been calling our past patients to see, are there any needs that we can help with? What are their concerns? So that we can adapt our programming to meet these needs that they have right now due to the isolation, probably due to eating habits that aren't quite their norm, and probably exercise that is a little less than their norm. So we do offer physical activity suggestions. We have something called Workout Wednesdays that again is offered by a couple of our therapists that are online with us today. There's a new workout every week. It's on our Facebook page, so anybody can join it. As well as there's some short little things we call exercise snacks. So rather than eating snacks, these are little exercise snacks that you can do in small tidbits of time. So these are all things that we would welcome your participation in. And also to go back to that tele-rehab project, we can now offer that throughout Georgia. We are obviously that it's the same license, whether we're living in Sandy Springs, Atlanta, or whether we're down in Albany or over in Savannah. So this is something that we are making available for folks in other areas of Georgia. We'll be working with community centers when that's appropriate, so that if they need in-clinic care, if they need mobilization, if they need garment measuring, if they need anything that's hands-on, we're looking to develop relationships in the community that can offer the specialized needs that can only be provided by hands-on. So that was my little 2 cents to add to Jill's. Many of our patients come to us and say we'd like to be treated, and we will help find those or get those referrals that are required. So we can take that off the lap of the referring nurse navigator as well. So there's our contact information should you want it. And with that, I'm going to turn it over to Katrina so that we can take a few minutes of Q&A.
All right, thank you so much. Thank you both. It was great to learn more about what you do and how we can all kind of build in that rehabilitation into recovery and treatment for the patients that we serve. All right, so we do want to take a few questions, but before I do that, I do want to make a few announcements to have for you. And the first one is that I would like you all to save the date for the annual meeting. It will be on August 29th. Of course, we'll send more information out via email and the listserv that we have. If you're not on the listserv, I'll be adding everyone who attended the webinar today to the listserv, so you'll receive the emails. The second announcement is that Georgia Core is partnering with Clarity Patient Advocates to host a webinar on next Tuesday, May 5th at 12 o'clock, and we'll be discussing how the pandemic is affecting cancer care. So if you would like to attend that, feel free to find that event on georgiacancerinfo.org, and also invite survivors and caregivers that may want to receive that information as well. And then we also have a meditation series that Georgia Core is hosting each Thursday at 9 a.m. We have hosted about 3 meditation series so far, and we have 3 more sessions to go. So we would like for you to join us in on that. I know that everyone's enduring a lot of stress during this time, so this would be a great time for you to take about 20 minutes for yourself to meditate. And feel free to share this as well with your colleagues or survivors that you support. It's every Thursday at 9 a.m. on Facebook Live. And we also have past sessions on our website, as on the Facebook website as well. All right, so we'll take a few questions. If you have any questions, you can put them in the chat. And someone had a question about telehealth being offered in other states. I believe that it's only offered for Georgians, is that correct? Okay, you're off mute.
Thanks. The issue of tele-rehab is one of license. So yes, we can densely go into Georgia now. We do have an alliance in the state of Louisiana. So we will be seeing patients in Louisiana. and our therapists are obtaining their licenses in Louisiana. I also carry a license in the state of California. So if you happen to be in California, our therapists can offer tele-rehab in California. If you have any states that you have a particular interest in us offering services, if you wouldn't mind letting us know, we will go after that. There is something called a compact in physical therapy, so that once we belong to a compact state, we can treat patients in 20 states. So part of the reasons of us getting a license in Louisiana is it is a compact state. Georgia is not yet. It has legislation and initiative, but once we have our licenses in Louisiana, there will be 20 additional states. How's that for a thorough line? You want to know?
Awesome, thank you. The next question is, what type of treatments do you offer for peripheral neuropathy?
I'm going to turn that over to Jill.
Okay. So some of the things that we do, it depends on hands versus feet, but we have one of the approaches is sensory desensitization, where we give patients a program where they actually do sensitization. I said D, but it's sensitization, sorry, where they actually use different textures, different kinds of stimulation to the skin that can actually help decrease some of the sensory changes that they're having. Exercise also has been shown, it increases certainly in diabetic neuropathy, not so much done in CIPN, where the mechanism we think is increased blood flow to the area that may help healing, or at least help some of the sensory changes. And the other piece of it would be, again, looking at some balance kinds of issues. Those sorts of things can actually help patients with the peripheral neuropathy as well.
What are the qualifications for financial assistance for rehab?
Jill, do you want to handle that?
So right now, as Marilyn mentioned, all of our programs are being offered at no patient charge because of COVID-19. So it's a special program that we're offering to all of our cancer patients, really in Georgia at this point, to access all of our tele-rehab services. We are billing insurance at this point, but we're telling patients and assuring them that there'll be no out-of-pocket costs. And that's funded by grants and donors and fundraising that we do. Once we are back to our usual TurningPoint method of operation, when patients are coming in and out of the clinic, there is a financial assistance program, as I said, for patients with, for example, Medicaid. Medicaid in Georgia, and actually I believe in most states, does not cover physical therapy outside of a hospital setting. And many hospitals don't accept Medicaid for rehabilitation. So a Medicaid patient, it can be a little bit stuck in terms of accessing resources. And there can also be a significant wait for rehabilitation. So the way we fill that gap with our patients that are on Medicaid is they're considered automatically on our financial assistance program. So our donors and our fundraising and grants cover their care. For patients that have insurance, and that they're having difficulty, many of our patients right now are out of work or have limited ability to work because they're cancer patients going through COVID-19. But they may have health insurance, but have difficulty with deductibles and copays, that kind of thing. In that case, there's a financial assistance program, and we look at a number of factors. It would be hard to list them, but it's basically income-based and need-based financial assistance for those patients. To be honest, by the time patients come to us, generally they have some form of insurance because they've gone through their surgery and initial diagnostics, even if it's an emergency Medicaid program. So we see all patients, as I said, regardless of their ability to pay, and work with them. I hope that answers the question without sounding like, well, there's maybe this and maybe that, but it's fairly individualized. But right now, as we said, no patient charge.
All right, awesome. And I'll share that, share your website whenever I send out the evaluation. I will be sending out a test and also an evaluation of the webinar today, so we would love your feedback. Do we have any last questions before we go? All right, well, thank you all so much. We look forward to seeing you at our next event. As usual, we'll send all communications out through the listserv, and let us know if you have any questions. Thank you.
Thank you. Thank you, everybody.
Bye.
Bye.